As Sam has said, our group is a relatively new one compared with Matthew's group. It doesn't have much of a history, and I'd just like to explain a little bit about what we are trying to achieve. We have two main areas of interest. One is grandly called venous thromboembolism, but this is about blood clotting, and people with cancer being treated for cancer are more prone to blood clotting, so it's an important area. And the other one is lymphedema. You may well know that many people who have treatment for cancer that involves removal of lymph glands may develop swelling. The most commonly recognised example is women who have lymph glands removed from the armpit area are prone to getting swelling of the arm after that type of surgery. So they're very much in the supportive care element of the spectrum that Sam was describing earlier. The other thing about our group is that we do have an interest in non-cancer as well. I think, although this is clearly part of the NCRI, I think it's been recognised that a lot of our issues do apply to people with other conditions. So some of our projects actually overlap and involve cancer patients and patients with other conditions with similar problems. So we are a small group. There are 5 of us that are part of the group. We have multidisciplinary background. We've had, as I mentioned, are a new group. We've had some of our group members have been involved in study development before the group was formed, so they are part of our portfolio. And others, the strength of the group, and as Matthew's already described, is we have expertise which can help us to develop our own studies or support others who may wish to develop studies for which we can give some advice. Just again, the detailed studies that we have are in the booklet that you've got, but we've got at the moment, we're involved with 6 studies that are currently open, 3 have recently closed, and as might be expected, 8 are in development at present. And what I'd like to do is, the other thing is that because we have an interest in other areas, some of our studies are actually primarily adopted by other CSGs. So, for example, one of the ones I'll be talking about later will be involved in lymphedema, but that actually belongs to the breast cancer CSG, and we're involved with that as well. So they're sort of co-adopted across the sites. So the 2 examples I thought I'd give you in a little bit of detail, just so that you get a flavour of what we're doing. One from each of our main interests. The first one is a study called SELECT-D, and the other one is a study of lymphedema called a BEA in place, and I'll explain those a little bit further. So SELECT-D, this is a study which the chief investigator is Annie Young, who's a member of our group, and you'll be hearing from her shortly because she's involved today. So if anybody has any questions about this study, Annie is here, and I think members of Annie's team are here as well, so they'll be able to look at this in more detail, and I apologise if I get bits wrong from this, but it's basically this is the sort of official title of the study, which is I should emphasise is a pilot study. It's a big pilot study, but it's a pilot study looking at comparing dalteparin, which is a low molecular weight heparin, which is an injectable anticoagulation agent, and rivaroxaban, which is an oral anticoagulation agent, one of the newer ones. And the idea is to assess which of these may be better in the full study, but this is a pilot to look at the practicalities of doing the study and be able to estimate sample size and things like that. And that's the main bit. And then there's a second phase, which is really looking at trying to get some idea, again, in the main study about what's the best duration of treatment. So this second phase is in people who have residual clot there or have had blood clot that's been affected the lungs. They'll have treatment of 6 months or 12 months duration. So that sounds a bit complicated, and when you're ever looking at studies, I always find looking at the patient information leaflet or the information on patient sites is much easier to understand the flow of the study. So this one is to describe, if you follow this through, you'll see that participants who are taking part in this study are randomly allocated to 2 groups, and they'll either receive 6 months of the injections or 6 months of the tablets, and at the end of that it'll be assessed as to whether they still have a blood clot or whether they've previously had a blood clot affecting the lungs as well. And if they have, those will be then randomized to two groups which will have either 6 months of treatment or 6 months of a placebo dummy tablet. And there'll be another one, but some of that will be 12 months as well, won't it? No, that'll be 12 months in total. That's right. Thank you very much. Good. So I'm afraid with any of these numbers, these figures are, I'm sure, out of date because they were the ones that we talked about at our meeting in March. But as I said, it's a pilot study, but it's a large pilot study with a target recruitment of over 500. And when we met in March, it was over 160. 192 now, and there were 43 centres, and there are probably now more than that because some are being opened. But anyway, so this is an ongoing study, and we don't have the results as yet, and the results will be used to design the major trial in the future. So that just gives you a bit of a flavour of the project. And then this one is the other one. This is the lymphedema study, which is the one I've been involved with. The chief investigator of this study is Nigel Bundred, who's a breast surgeon in Manchester, but I'm one of the co-investigators, and it's been funded by an NIHR program grant. And what it's looking at are two particular projects. One is to look at the early detection of lymphedema after breast cancer treatment, and the second is to see if there are things we can do to prevent the development of lymphedema by intervention with compression garments. Why is this important? We know that if you develop mild lymphedema, it's much easier to treat. Lymphedema, unfortunately, has a tendency to become more difficult to treat as time goes by. What starts off as a swelling in the arm, for example, in this study, that's the area we're interested in, is very fluid to begin with. It's very soft, and if you press on the arm, you can dent the fluid. But as time goes by, a complicated process happens, and fat and scar tissue are deposited. And as that happens, it becomes much less easy to treat with our conventional treatments that we have at present. The other issue that's been raised is there's been an American study which suggested that early treatment may actually prevent progression to more complicated lymphedema, or even progression to lymphedema at all. And that's what's meant by the third bullet point. If you can detect what we call a subclinical change, in other words, a very mild swelling that isn't detectable by examination, and patients may not feel particularly affected by it, then there is some suggestion that if we can intervene at that stage, it may prevent the development of full-blown lymphedema. So how do we detect lymphedema? Well, there are two main ways. Firstly, we can measure the arm, measure the volume of the arm, and we compare that with the other arm on the side that's not been operated on. And customarily, any of you that have been involved with lymphedema will be aware that tape measures are used to measure the circumference of the arm at different places, and then we put that into a computer and calculate the volume of the arm. Alternatively, there's a more sensitive method, which is a thing called a pyrometer, which this is. So as you can see, there's a person has their arm in this frame, and the frame's just slid up along the arm, and basically some infrared lights are shone on the arm, and a computer system calculates the circumference of the arm at different places and then turns that into a volume. So because it does it more frequently along the arm than the 4 centimetres that normally use when you use a tape measure, it becomes a more accurate method. And the second method is an electrical method. When you start to get lymphedema, the fluid in your arm increases, so the fluid in the tissue spaces increases, and you can measure that by putting electric current through the arm. It's an alternating current, and so instead of resistance, it's called bioimpedance, and it's a technology that's used a lot in gyms for measuring fat and lean body mass and things like that. But here we're looking at extracellular fluid volume. And there is evidence from some work done in Australia that if you measure people with this device after they've had breast cancer surgery, it may be more sensitive at picking up lymphedema earlier than using a volume method. And this is the particular various different bioimpedance devices. This is the particular one that we are using in the study. So the person has to lie down, and as you can see, there's some electrodes placed on the arms and leg, and a current which you can't feel goes through those, and a little gadget measures the bioimpedance for us and converts it into something we can understand. So the study, the BEA study, is using this technique of bioimpedance to try to detect lymphedema earlier. It's a multi-centre study in the UK. It's about, I think we had 8 or 9 centres, and we were comparing bioimpedance with pyrometry. It's a study that's ongoing. It's another large study. Quite a lot of our previous work in palliative and supportive care have been really quite small studies, and it's really exciting to see that we're getting some big numbers now, which strengthen the validity of the results. So this was aimed to recruit 1,100 women, and we finished the recruitment in January of this year. One of the, I think, important points here is that I've put the number we recruited in Derby. It's not to say, oh, didn't we do well, but it's actually patients were really keen to be involved with this. Of the people who were eligible to take part in it, something like 88% of them did take part, and that's a huge number. That's really, we're really grateful to them for that. So just to give you a little flavour, this is a study that's ongoing. The follow-up's for 5 years. We won't have all the results for quite some time. But we've got some interim analysis here, which is, I think, worth sharing. So it'll give you a flavour of what will happen in the future. So in this study, so far, this was after 550 people had been recruited. And we define lymphedema, this is a bit debatable, but by definition in this study, lymphedema is defined as a 10% increase in the volume of the arm compared with the baseline, which is done pre-operatively. So everybody has a measurement pre-operatively. And you make some adjustments for the other arm as well. So if somebody puts on weight, their other arm will get bigger. You might expect their arm that we're concerned about to get bigger too. So there's an adjustment for that. And if we use that definition, at 12 months, the incidence of lymphedema was 13.7%, and at 2 years, it was 25%. And that's sort of roughly what we're seeing internationally. Roughly 20% of women who have an axillary node clearance, the lymph glands removed from the armpit, will develop lymphedema. What was interesting in this study is that there were some predictive factors that we were able to look at, and when we look at the 1,100, we'll have more of these. The one I'll just focus on here is the last one, which is relative arm volume change at 6 months, more than 5%, less than 10%. What does that mean? It means that if a woman has a small swelling of the arm of between 5 and 10, and more than 5% but less than 10%, they are then more likely to go on to develop lymphedema. So if at 6 months you have that swelling, you're more likely to go on to get lymphedema. If you don't have that degree of swelling at 6 months, you're much less likely. It's not impossible, but much less likely to get lymphedema. And that raises the issue about if we're going to look at prevention or doing things for people, this is a group of people that might be more at risk. Okay, and then the other study is the prevention study, which is a randomized controlled trial, which is looking at using a compression garment in people who may be at risk of lymphedema, and putting the garment on every day for a year in the treatment group, and in the control group just having standard care, which is advice about how to manage the arm without using a garment. The outcome measure here is how many people have lymphedema at 1 year and 18 months after the randomization. This is a more difficult study to recruit to, as many of our studies are, but we've got to 110 now out of the target of 270, and this will again need a long follow-up. So hopefully at a conference in the future we can let you know the results. One of the things that's emerging from work on breast cancer and lymphedema, which we're also looking at as a future project linked to these, is that it's becoming clearer that there may be a vulnerability in some women to develop this. It's not just a random process. And there's now thinking that there may be genetic predisposition, so that's something we're hoping to have funding to look at based on the patients that are involved with our study. So I think hopefully this group is starting to do some useful work, and hopefully in the future we'll be able to share more results with you. Thank you.
Thank you very much.